Good evening, everyone. This is Dr. Satya Yadav. On behalf of SPECT, Society for Pediatric Cell Therapy and Transplant, I invite you to 10th edition of our webinars. And today's topic is super exciting, and it's something which needs both science and art. So these are the transplants for primary immunodeficiency disorders. I think one of the most challenging and difficult ones. And today we have exciting lineup of speakers and panelists and everyone. But before we go there, I will invite today's chairperson, none other than Dr. Mohammad Ramzan Khan. Ramzan was our fellow at Gangaram Hospital many years back. And after that, he went to Sick Kids, did his BMT training there. And he came back, worked in Manipal, Jaipur, and then he worked in AIMS, Jodhpur. And now he's in Burjeel Hospital in Abu Dhabi, working as a consultant there. So Ramzan has been always been an academician. He has published a lot of research papers, and it's a pleasure to have him here today as a chairperson. So over to Dr. Ramzan to take proceedings further. Thank you.
Good evening to all. Thank you so much sir, for the nice introduction. Today we are having session of primary immunodeficiency that are having guest speaker with us, Dr. Chopra from Hematology Oncology at Hospital for. Hello.
Yeah, we can hear you. Please carry on.
The voice is not clear actually. I think it's not doesn't have a good network or something.
He is dedicated to advancing gene therapy for currently he is the lead principal investigator for gene therapy trials for children between 15 to 12 years old with thalassemia and leading novel protocol FABS for stem cell transplant in children with thalassemia. He is also the principal investigator for 3 NIH-funded trials, which is focused mainly on symptoms scale for the children with chronic GVHD, reducing transplant morbidity in severe combined immunodeficiency patients, and epidemiology and outcome of delirium in PIDS bone marrow transplant patients. Coming to further, his research is focused on decreasing transplant-related morbidity through both retrospective analysis of institutional as well as CIBMTR databases like evaluating infections, early and late pulmonary toxicity, neurological toxicity, managing both acute and chronic graft versus host disease, and prevention of acute GVHD with the gut immunomodulation with vedolizumab, and finally reducing the risk of GVHD by assessing levofloxacin as. So such a vast experience, I would love to call Dr. Yogi to start his talk on inborn era of immunity. Thanks.
Thank you, Dr. Ramzan, for the kind introduction. So, Dr. Satinder had reached out to me for this talk. And this is different from what we see. Like we'll not talk about conditioning. We are not talking about GVHD, but we are talking about what happens pre and how much effort we need to put before even thinking about conditioning and GVHD prophylaxis and all that. And I'll be focusing on that part. And we call that as prehabilitation, and then we'll focus on what prehabilitation is in the talk. Okay. So I have no financial interest or conflict of interest. The only thing which I want to highlight is we'll be discussing about something called as vedolizumab, which is a alpha 4 beta 7 integrin inhibitor, which we had used in kids with immunodeficiency and colitis, and we saw good results in prevention of gut GVHD. But this is an off-label use, so this is not what FDA has approved or Health Canada has approved. So the learning objectives in the talk will be what is the actual meaning of prehabilitation? Where are we with early diagnosis and management of inborn error of immunity? What is the role of newborn screen, which is available in North America? And how does it impact in the outcomes? What are the comorbidities which are associated with either SCID or non-SCID population? And then what do we do pre-transplant to manage those? Controlling the inflammation is key. And then what is the data on bridging therapies? And we'll highlight some HLH experience which has helped in making these transplants successful. And lastly, we'll talk about IBD, inflammatory bowel disease, and our own SICKIDS vedolizumab experience. And why I chose IBD, because IBD or colitis is seen in a multitude of IEIs or in one error of immunities. So as we know, in these disorders, they're heterogeneous group. They can affect innate and adaptive immune system. They can affect T cells, B cells, neutrophils, macrophages, natural killer cells. You name them, you can find an immune deficiency with these things. There are more than 400 distinct IIs which have been identified, so you cannot remember all of them. But what we'll be discussing will be the crux and the few common ones. SCID is considered to be the most profound of all because of the dysfunction of T and B cells which it comes with. And this is where the world is moving. The world is moving to precision medicine, which means all the SCIDs are not same, all CGDs are not same, XLPs are not same. So if we can diagnose something early, we can prevent the comorbidities. If we can diagnose something early, then we know if there are any targeted therapies which are available to control the disease, even before we think about bringing them to transplant. If we diagnose something early, then we can at least put them on surveillance, put them on prophylaxis. We can prevent the infections from happening. So we'll be focusing on the left half rather than the right half, which includes the conditioning part. So what is prehabilitation? So prehabilitation is derived from something from our surgery colleagues. So they say this as a pre-surgical process which enhances the physical, nutritional, mental, medical condition before surgery. And the whole goal of that is to improve the outcomes post-op. So how does it fit in our context of stem cell transplant, and especially with the IIS with multiple comorbidities? It's the similar process where you have to make sure that the kid who you are taking to transplant is nutritionally strong, has mental stability, is physically strong, to improve the condition, to control the inflammation, to make sure that you have a better outcome post-transplant. We are not even talking about donor choices. We are not even talking about conditioning. Again, this will depend how much time you have depending upon the condition. So if you have SCID, then you may not have all the time in the world to take them to transplant. But for the non-SCIDs, you have time in your side to manage the comorbidities before you think of bringing them to transplant. These are all immunodeficiencies which are highlighted. It's impossible to remember each one of them, but this is just to tell you, like, you name it and then you will have them. You can have a T negative, B negative, NK positive. They can come with radiation sensitivity, without radiation sensitivity. But once the diagnosis is made, then you have to think beyond that. What this diagnosis will lead me to? Is this disease transplantable or not? For example, if we look at the left-hand side, the FOXN1, these are the defects in the thymocytes in the thymus. We don't do transplant there because this cannot be cured by stem cell, hematopoietic stem cells. So you have to be careful when you're choosing the patient. Similarly, these are the list of combined immunodeficiencies. We see commonly DOC8 here. And similarly, we see in India, like very, very common. They come with a lot of issues. They can come with viral infection, fungal infection, skin infection. So you need to manage all those before even you think of taking these patients to transplant. And then there can be other disorders which are common, which we see. CGD is very, very common. Leukocyte adhesion deficiency. There's a big paper from India from Dr. Revati Raj. So we see that. We see HLH very commonly, familial HLH. We see IPEX syndrome. And then there can be immunodeficiencies which are associated with other syndromes like cartilage hair, hypoplasia, deficiency, CHART syndrome. So once the diagnosis is made, then you have to look at the various organs which these organs which can be affected by them and then try to manage. Viscot Aldrich, what will you see? You can see skin inflammation, you can see colitis. So you try to manage all those before coming to transplant. And the reason why we want to do this is I'll explain in my further slides. So what has changed in immunodeficiency, and this is a big game changer in Canada and in North America, is newborn screening. And why this is a big game changer? Because what they have seen is if you can pick them early, then you can take them to transplant early before even the comorbidities has developed. So forget about managing infection, forget about managing multi-organ failure. Here you are picking them up so early. So in Canada, we have newborn screening available in 7 provinces. It's a test which they put the dried blood, they send it to the lab, and they see how the T cell manufacturing from the thymus is and what is the amount of the T cell receptor excision circle, Tregs. In pure SCID, this number is considered to be less than 25, and that's how they come to the cutoff or come to the diagnosis of whether this kid has SCID or not. But just for the screening, what they have done in Canada, they have put the cutoff as 75. And the issue with that is that you will pick up all those who are non-SCIDs, which is okay for a screening test, because then you will go for the molecular diagnosis. So this is the newborn screening, how much effort it takes to find one SCID patient. This is on the left is the experience in California, and the right is experience in British Columbia, which is in Canada. So they found that after doing all the testing, especially in British Columbia, you see they tested almost lakh patient, and then they only found 116 to be positive. Out of that, 66 were referred for further flow cytometry, and they only found one SCID out of this. So that is a huge effort to put to find one SCID. So whether this is feasible in Indian circumstances or not, that is a question for the panelist. But this is what they found. So similarly for the non-SCID, they still found 4 infants with II, and this is we're talking about a screening period for 4 years. So in 4 years, the cost for this test is almost like $10. So they spend $1 million to find one SCID, if you can put in that way, which is not that much cost effective. But they also found other patients. They found patients who had non-SCID, and then if you combine everything, then this may be a cost-effective strategy. Similarly, in California, when they did the testing, the abnormal Treg or abnormal testing was only in 0.1%. When they tested the 0.1%, only 9% was SCID. The rest had either secondary lymphopenia because of other causes, like heart disease, other congenital abnormalities. Some had neonatal leukemia, or some like 33% congenital syndrome, like D. George, which is very, very common, trisomy 21, or Down syndrome, which is common. Rare diseases are ataxia telangiectasia. So in all, if you think that in Hindi this can be खुदा पहाड़ और निकला चूहा, आपने इतना ज्यादा पैसा खर्च किया पर आप एक ही पेशेंट को डायग्नोस कर पाए, but this is what they think is cost effective here. So it's finding a needle in this haystack. And why this is important? So this is the CIBMTR data on SCID, which is showing us the impact of the newborn screening. So if you see the graph A, from 1974 to 99, the overall survival for SCID was only 64%, which improved up to 80. But beyond 2000, there has not been much improvement. And the reason is because you have changed your conditioning, you have become reduced toxicity myeloablative. In prior years, they were not using conditioning in most of the patients. Also, you have a vast majority of unrated donor pool, which is available to improve your results. But why from 2000 to 2016, there was not much impact in improvement of the results? And the reason is when they further isolated the patients from 2010 and 2016, in those 6 years, They found if you were diagnosed with the newborn screen, your outcome was 94%, which is a big change, which is almost like 30 points up from previous 30 years or previous 40 years. And those patients who were not diagnosed by newborn screening, they were diagnosed at first infection, their outcomes were similar to who were diagnosed in early 2000. So whatever impact of conditioning or unlimited donor pool happened in the first 2000 or 2010. Beyond that, the major impact and improvement in the overall survival was if you catch them before their first infection, if you catch them early, if you catch them on newborn screening. So that has been the impact of the newborn screening. We all have seen this paper by PI in which they had done assessment of 25 centers with 240 infants, which were the part of the Pediatric Immunodeficiency Consortium of North America, and SPCTT is also part of this. The age less than 3.5 months, it's a cutoff where they found the most effectiveness. But if you pick them the early without their first infection, then the outcome is better. So this is what it shows, and this is before the newborn screening. So after the newborn screening, like we have that available at SPCTT, and then we try to take them to transplant at around 12 weeks before their first infection. So what did we learn from this experience? That newborn screening for SCID is essential if you want to really improve their outcome post-transplant. We're not even talking about cord blood, non-cord blood, different kind of donor scenario. We're not even talking about TCR alpha beta depletion. But in this single test definitely helped in improving the outcomes. And if you take SCID patients before infection, which is very well known, then they will have better outcomes post-transplant. So what do we do for the comorbidities, which is very, very common? They present with a lot of comorbidities when they're first diagnosed, if you don't have a newborn screening. So we try to manage. We try to gain some time if we can, because SCID is an emergency. So sometimes you don't have time, but you will do your best to control the bacterial infection. You will do best to control thrush. You will screen for the viruses. For RSV, if this is a season, then you will start the prophylaxis so that they don't get the RSV. You will start them with IVIG. You will start them with Septra for PJP. For antifungal, you will start them on fluconazole or itraconazole or whatever your standard of care is. So you try to first prevent the infection by giving them prophylaxis. If infection is already developed when they have been diagnosed, then you try to manage. But you don't have much time. You don't have much leeway. You have to still take them to transplant as soon as you have controlled the infection. What about other comorbidities with non-SCIDs? So that is a multitude. There's a big, but what I try to do is I try to summarize most common ones because they can present with malnutrition, they can present with inflammation, they can present with infection with different kind of organisms. CGD, Burkholderia is Cepacia is the common one. They can present with recurrent abscesses. They can present with autoimmunity, common in Viscott-Aldrich syndrome, common in other kind of immunodeficiencies. They can present with silent-pulmonary infection. Bronchiectasis, very common we see with CGD. A 10-year-old CGD patient coming in has no evidence of colitis, and then recurrent respiratory infections. You have bronchiectasis, and then you do an OB, and then the OB is low. They can present with rash, they can present with eczema, common with the Dockade. We have seen that the rash can become very, very severe sometimes. Hepatitis, Viscott-Aldrich, very, very common. Colitis, we'll have a separate discussion, but there are multiple IEIS which can present with colitis. And what happens, this leads to prolonged inflammation will lead to some damage to the intestine. They can develop fistula, they can develop fissure. Some IEIs can present with malignancy, so they have to be screened for that. We have few cases which were diagnosed late, so they can present with malignancy like APDS2 and all those. Thrombocytopenia is common in Viscott-Aldrich syndrome in those conditions, so you have to manage them pre-transplant. When we look at the CIBMTR data, the outcome for non-SCIDs is always on the lower side than the SCID. Because for SCID, as soon as you diagnose, you will do something. You will prevent them from getting the comorbidities. You will take them to transplant. For other conditions, there's not been a straightforward road because previously for a milder VAS or VAS, which we'll see in our panel discussion that terminology is going out, and then there is no mild form. People are recommending to do transplant even if the score is low. those patients used to stay for long. And then those patients used to get a lot of comorbidities. And when you take them to transplant later with the comorbidities, and the outcome is poor. Similarly, for the CGDs who are less symptomatic, their quality of life may become poor by repeated infection. But when you take them to transplant when they are adults in their later age, then your outcomes are not that good. For HLH is a similar kind of phenomena. If it's not familial HLH, then or they're picked up late, or they present to you first at 10 years of age, then because of the inflammation, you don't get a good outcome. So you have to be careful in interpreting this. In Europe, because that was the North American data, they have seen similar outcomes. All those patients who had pre-existing lung and liver damage, they had poor outcome, which means either you do the transplant before they get damaged, or if they have damage, then you try to manage that damage first before taking them to transplant. And they had similar outcomes that if you are taking them before infection, then that might give you a better outcome. So this is the Andrew Generi paper who did all the European data here, and then they show that the respiratory impairment itself can give you poor outcomes. So you have to catch them before that happens. So when we are bringing these patients to transplant, then you have to have a strong hold on each and every organ which can be affected, and then try to manage all these before even pressing the green button of transplant. So if you screen them for infection, if they have CMV, then you have to make sure that you have used all your agents available to control at least the infection. It may be difficult to make it negative, but at least control. Inflammation, we'll discuss why this is very, very important, but the key is always to control the inflammation with steroids, with whatever agents are available. We have access to amipalimab, we have access to Roxo here. Amipalimab may be difficult to get in India, but if you can, then why not? Especially for the HLH-like condition. Sinopulmonary infection, again, you can give a referral to ENT. Make sure there's no mucor there before you even take them to transplant. Rule out fungus, treat the bacteria before even thinking of jumping to transplant. CT chest may be needed to diagnose bronchiectasis. Respirology referral. We at SickKids will send them for a BAL to understand what is happening, with what kind of bacteria are we dealing with, what is the sensitivity, before even attempting to take them to transplant, because that will give you the idea that what complications they can develop. They can develop the same bugs in the blood, in the bloodstream, so that you're well prepared with the antibiotic spectrum. You have the sensitivity before, and chest CT becomes important. For hepatitis, you have to evaluate for all the etiology, which can be, and then you can say this is autoimmune. So we'll send the hepatitis panel, make sure there's no hepatitis B, no hepatitis C. And in some cases, they may need a steroid before even they come to transplant, just to calm the liver down, because most of your chemotherapy medications will be metabolized. Inflammatory bowel disease is something which we worry about, because that can increase the risk of gut GVHD. And we put a lot of effort in controlling this inflammation. It's not always possible. They are on multiple immunosuppressions before we do that. And these are the multiple agents which we have seen in our experience. They help. Abatacept can help in LRBA or CTLA4 deficiency. Vidlozumab will discuss how it helped in our patients. If they have fistula, fissure, you have to have a strong management. Sitz bath, what will you do at the time, especially when they get mucositis in transplant? So you try to manage and try to start all those processes before taking them. And for rash and eczema, mostly we have seen that it goes away as soon as you start your serotherapy. But if you can manage that, control that, then that is the best to reduce the risk of skin GVHD. So the inflammation is key. And then this slide is showing the effect of inflammation on hematopoietic stem cells. And this is one of the most important things to control before we think of taking a patient to transplant, and why. So if you see here, prolonged cytokine exposure on the hematopoietic stem cells is not good. And hematopoietic stem cells have ability to divide. They have ability, they are pluripotent, correct? So in case they are having a prolonged inflammation, what they will do is they will say, this is not our time to divide, we'll go in the resting phase, which is the G0 phase. And when does this happen? This happens if you have a chronic inflammation with type 1 interferon. It happens when you have TNF alpha. So they will not go into the Sen cycle. They will lose their pluripotency. They will lose to divide. They will forget to divide. And when they lose the self-renal capacity, you will lose the hematopoietic stem cells. So this is very, very important to understand, because sometimes, especially like in a condition like HLH, if you take them to transplant when they have more inflammation, then at G0, your chemotherapy may or may not be effective, because most of the chemotherapy works in the mitotic phase, G2 phase, or S phase. So these stem cells from the recipient can remain quiescent for some time and then come back and become pluripotent, because now there's no inflammation, correct? And then you can see mixed chimerism, you can see graft rejection at that time point, because they can kick out the donor hematopoietic stem cells. So controlling the inflammation becomes very, very important. So what do we do? So this slide is showing uh, what can we do in terms of bridging prior to transplant, correct? Because this precision-based therapy are available. We have targeted agents these days which we can use. For HLH, we have various pathways which we can block because we want to control the inflammation. We don't want graft failure. We don't want mixed chimerism. We don't want secondary graft failure. And these are the multiple agents which have been used. I'll talk about amipelimab separately because that has the best data available for the HLH. But we have ruxolitinib, where you can block the JAK pathway, and you can definitely block the downstreaming, and you can block the cytokines, you can block the all the cytokines like interleukin 2, 7, etc. Same is with anakinra, you can block the IL-1. And on the middle is basically how abatacept works for the CTLA-4 and LRBA. So where the CTLA-4 will combine with the CD80 and CD86 because it has more affinity than the CD28 molecule, and that can cause the T cell activation and then cause the release of the cytokines. If you give abatacept, then it will competitively inhibit and then attach to the CD80 and CD86 will prevent the T cell activation, and that's how it helps us in blocking this. It can help in controlling the inflammation. It can help in controlling the colitis, which happens with these conditions. And we use it very, very commonly pre-transplant before we are bringing these patients in, so that when we are bringing them in, the inflammation, the colon is calm. Linezolid is a newer agent which has been used for the PI3K delta activation. It blocks the activation, it decreases the lymph proliferation, it decreases the T cells, it decreases the B cells. And few papers from NIH have labeled this as a single agent treatment, and you don't even need to take the patients to transplant, which is still conflicting because nobody knows how long this has to continue before you can make that decision. But NIH is favoring this drug, and then if you are in NIH and you have APDS, then they will not take you to transplant. So word on amipelimab, because this is we struggle with HLH. We struggle with controlling the inflammation with HLH. We struggle with graft failure. We struggle with mixed chimerism. And this publication in NEGM from Locatelli clearly states that the patients who got amipelimab they had blocked the cytokine, they did better in terms of engraftment. They did better in terms of less mixed chimerism. So this is what this paper is all about. And interestingly, we were the participant in SICKITS in this. We had 2 patients, and all those patients who receive amipelimab pre-transplant, because you had blocked the gamma interferon, when they measured the level of amipelimab antibody 1 year post transplant, they still had amipelimab because there was nothing to block. The amipelimab was not used at all, so which was interesting to see. So 91% of the patients who receive amipelimab had engrafted, which is rare when you think about HLH, because this shows you that the HLH was under good control for these patients. And then post-survival probability at 1 year was 91%, which is amazing. So if you have access to biological modifiers, then that is the best, because you can at least control the inflammation. You can block the various pathways which will impact the success of your transplant. And this is all happening before even we are taking them to transplant. The IBD is a different beast because we see inflammatory bowel disease in II in various disorders. We see them in Viscott-Ullrich, they can develop colitis. We see with LRBA commonly they can develop colitis. ZIAP deficiency will come with some colitis. CTLA4 will come with colitis. We have CGD patients, NCF1, who can come with colitis. So because it's so rampant and so various kind of immunodeficiency, we have a very early onset IBD program at sick kids, where all patients who are less than 5 and who have developed IBD, they'll be screened for immunodeficiency, and that's how they get picked up early. So vedolizumab is one of the interesting medications. This is alpha-4 beta-7 integrin blocker, which will go and combine with the molecule called as MADCAM on the intestine, and then it'll prevent the T cells to join there, because the T cells cannot join. So then there'll be no homing of the T cells. There's no rolling of the T cells. The T cells will not enter through the broken endothelium because they cannot combine. They cannot combine with the molecule. People have used this in IBDs. People have used this. There was a trial for GVHD prevention, but this trial was more than 12 years in adults in preventing the lower gut GVHD, but not in the setting of colitis and then how it prevents GVHD. So that's the difference. We use it by accident. So we had a patient who was referred to us from a very early onset IBD clinic, and we had no idea what to do. He was on vedolizumab, and then what we found that with vedolizumab being on, the colitis was very well in control. We were able to do the transplant safely, and we did not need much doses post-transplant. So this is our experience at Sick Kids, what we did. Uh, for our IEI patients, this is our standard of care conditioning. We use triosulfan, fludarabine, and cyclophosphamide, and we also give serotherapy. Uh, this is irrespective of the graft source. Even for the bone marrow, we'll use this regime because that ADG will help to control or suppress the immune system rather than the GVHD. For GVHD prophylaxis, we have a common. We are a tacrolimus center. Every place has their own agent, and then methotrexate or steroids is our second agent as a backbone. So we made sure that these kids who were coming to us, their inflammation was under control. They got 3 doses of vedolizumab at 6 weeks, 4 weeks, 2 weeks, 6 weeks, 4 weeks, and 1 week apart. And the dosing, because we needed help of our GI colleagues, as there was no data on the dosing, but they were using this dosing in patients with ulcerative colitis and Crohn's disease. So this is the dose which they had advised us, and this is, I think, now the standard of care for them. And we had 11 children who went to transplant with this regime. And I'll show you their baseline characteristics. Uh, they were as young as 3 months and then as old as 14 years. We had multitude of immunodeficiencies, IL-10 deficiency. Commonly, it can have very bad GI effects. So they can develop anal fistulas and fissures. We had CGD, which can give you similar kind of GI colitis. We had a gain of sick mutation. We had a CGD. This was very tough case. It had a short bowel syndrome, and we were not sure whether this kid, even with the GTO, will tolerate the tacrolimus as an immunosuppression. So pre-transplant, what we did was because it's CGD, we put them on an antifungal, which is like voriconazole, and we tested the voriconazole level through the G tube, and we saw that this patient was not even able to absorb the voriconazole. So we had already planned and already counseled the family that you will have a long inpatient admission because we cannot deliver you the tacrolimus in a safe manner. It will be IV tacrolimus till we are sure that there is no GVHD. We had a case with IPEX syndrome and ZGAP. Conditioning was same as I had mentioned earlier. They had different donor sources. We had 2 haploidentical transplants in the same sets, but this dose of cyclo pre-transplant was lower. Post-transplant cyclophosphamide was standard 50 milligram per kg on day plus 3, day plus 4. But rest of them got a similar kind of immunosuppression. And if you see why there's a difference in the vedolizumab doses pre-transplant is because it took that much time, especially for the haplos, to come to transplant because there was not much data, especially for the CGD at that time point. There's a recent paper now. So that was hesitancy of the family, hesitancy of the parents. But their their colitis was very well controlled when we did that. But most of them did get 3 doses before coming to transplant. And this is what we saw. We saw that uh, all the patients who got vedolizumab pre and who had controlled colitis, like we did not had anybody with active symptom, they did not flare up. They did not get gut GVHD. There was 4 patients who got only grade 1 skin GVHD. Uh, the viral reactivations was similar, what we see with any kind of condition. The haplos had slightly higher viral reactivation. Similar was the case with the unrelated donor. So there was no increase in the viral reactivations because of the vedolizumab itself. But the key point was that none of the patients, they developed gut GVHD, which is interesting. And post-transplant, if you see how many doses, because initially we were not sure whether this will work or not. So the first couple of patients, they got more doses of vedolizumab. But if you remember, going back to the emapalumab, where we saw that the emapalumab was floating in 1 year post-transplant, we decided that we'll only give 1 dose post-transplant. Unfortunately, there are the company can do the vedolizumab levels. We did not have the money to do that, but if we plan for a future trial, then that will be the thing to prove that vedolizumab is still floating in your body. So most of these patients are doing well in the follow-up. None of them have developed any acute or chronic gut GVHD, which is amazing. Most of them have now healing perianal fistulas. There were one who had a stoma which has been closed. One had a rectal prolapse, obviously, which is still present. It will take time to go away. And the perianal fistula will also take time to heal. All of them are alive. We had no death. So vedolizumab helped in our scenario, and it can be used as a prophylaxis in this setting to prevent gut GVHD. We were able to discontinue the medication early, and then this platform will provide a base for the future trial for somebody with IAI and intestinal comorbidity. The other aspect, which is less looked upon, and even at sick kids, like we don't have that much support, but it still is helpful to if you have the ability to get a social work involvement to connect the families, to provide the families with resources, because compliance is the key. If they don't take the Septra, they don't take IVIG, so that poor compliance can lead to a big downfall. It can lead to infections. So that has to be sorted before they even come to transplant. And nutritional support is also important. We don't have the resources to focus on that, but what we have seen is that those kids who need GTU, we put them before they come to transplant, so that we don't have those kind of issues post. So to conclude, the transplant strategies are changing and they're getting more personalized. And we learned that the newborn screening is essential to diagnose kid early, and that has a huge impact on the outcome. The prehabilitation is also important. Controlling the inflammation is important. Controlling the colitis part is important. If there's a pre-existing organ damage, then that has to be managed optimally, even before we think about taking these patients to transplant. This is the entire team at SickKids. We work in collaboration with our IBD program because otherwise we would not have the access to the vedolizumab. And we have everybody to thank. We thank our patient and families. We have a lot of referral center throughout the Ontario and also in the northern provinces. So that's why we get so many patients here. And I'm open to questions.
Thank you, Yogi, for a wonderful talk.
Sorry, I can see there's something in the chat. So
One of the questions says, have you looked at the CMV recipient and donor status with CMV reactivation?
yeah, we do that routinely. Yeah.
So before others ask the question, so I would just like to ask one more thing to you. It's regarding HLH and your experience with gamma interferon blocker. Like
Yes.
you use it at what stage? Like before you like there are some certain criteria which patients you use it, or you give it to all before transplant.
So yeah, so we have like a separate HLH team here, And what they're doing now is they're using it for everybody. So initially, like if you have not getting control with DEXA, then they will not go to the etoposide. They'll start using the blockade. So this is the difference, because they have the access to that. And then some patients, if that doesn't work, then they will put them on ruxolitinib also. Yeah, the issue is when they started using it first, they were not following the viruses, which was very, very important, because we had a patient who got amipelimab and they did not check the viral load and then landed up with the CMV reactivation to an extent that we had to hold the patient for transplant. The CMV were, uh, I'll say 640,000 copies, like it was huge number. And that patient could not come to transplant. And we had a big discussion with Michael B. Jordan from Cincinnati. And then he said, "Oh, you cannot take this patient to transplant even." So we had to first treat the CMV, because that can be the issue with amipelimab. And then they started monitoring closely, and then because you want to pick them up early to control the infection. So this is what they're doing at Sick Kids.
And one more question on HLH. Like,
Yes.
all I know, this talk is all about preparing the patient for transplant, but
Yeah.
in terms of like a place of Jakavi prophylaxis post transplant or immediately after transplant,
Yeah.
is there any experience in that? Have you used in any of your patients or any?
So
Yeah.
So that's a very good question. So we have used that as a also for to prevent GVHD, or we start seeing GVHD, we put them on Roxo early in that scenario. So we have used that in both, but that is not a standard of care. We will still use our CNI plus the second agent as the backbone. But sometimes, like we had a patient with HLH where it was very, very difficult to control the HLH. So the question was, should we stop the Roxo pre-transplant, or we continue, or we don't stop it? So we gave a, I'll say, 21-day gap in that, and then we restarted the Roxo early post-transplant because of the risk of reactivation.
Okay, now I think there are a few questions in the chat
But
box. So Virendra is asking you, experience
yes,
of your team with vedolizumab used post-transplant for gut GVHD.
yeah. So that's a very good question. I had a patient recently, uh, 10 kg, with a combined immunodeficiency, 9 out of 10 donor. That was the only donor available. Developed grade 4 gut GVHD. So a 10 kg, and then this kid started having, like we didn't use vedolizumab pre. This kid had stool output was 4 liters per day, blood in the stool, requiring 3 albumin transfusions every 8 hours. So like a ICU kind of care was given on bone marrow transplant unit. And then that patient, we had to go all out. Like we used vedolizumab in that patient to see, along with Roxo, along with, you can name infliximab, you can name anything. We pour everything on this kid. That kid has survived. That is our first patient with the grade 4 gut GVHD surviving here. So we have used that post transplant for treatment of gut GVHD, and not a standard of care.
So any further questions, Ramzan? You want to ask any question to Yogi?
Yeah, sure. I'm having one question regarding the vedolizumab use, right? So in which
Yeah.
patients you use like only diarrhea on the colitis, or you check like stool style protecting
Yeah.
level in stool? So do
Yeah.
you
So
monitor with that, or each and every patient, just like if a simple patient is having like diarrhea and you use that?
yeah, so that's a very good point. Yeah, we do monitor the stool calprotectin. We have a patient who is coming in for transplant now. IL-10 deficiency. The stool calprotectin was 1800 on vedolizumab, because that was started by the very early onset IBD clinic. But they had not tried steroids pre. So now this patient was on anakinra, this patient was on infliximab, and then we not responding. They added vedolizumab, not responding. So we said, okay, because we have to take this patient to transplant, we cannot do it with this kind of inflammation, and the only donor is haplo. So we decided to put the kid on steroids. So the stool calprotectin has gone down by 10 times, and now we will be taking this patient to transplant, because if we don't put that much effort pre, then we'll land up with definitely with GVHD. Yeah.
So
So is there
Yogi,
any
there
cutoff for
is
stool protecting level?
Sorry.
Like if it is less than 100, or you should go for bone marrow transplant, like is there any stool cell
So
protecting level like cutoff?
yeah, so there is no cutoff. This patient had a level of 1800, and now it's 110. So
110. So it
But
will
we'll
grant
definitely, we'll, de we'll definitely, yeah, 100 is the cutoff, yeah. But we'll definitely go with the symptoms, correct? So patient has no evidence of colitis at this time point, has passing normal stools, there's no blood in stool. We'll do a ultrasound to see if there's any bowel wall thickness. If the bowels are looking okay, then we'll proceed. Yeah, it's symptomatic plus the stool calprotectin, but there's no cutoff. Yeah.
So there is a question in the chat box from Dr. Shweta Pathak. She says,
Yes.
your thought on pre-transplant preparation in Shirya-Kagashi syndrome, having recurrent infections and planned for haplo.
Yeah, that's a tough one. We have not done any Chidiak Higashi here at SickKids. But yeah, like my thoughts are always the same. Like you will see like which organ is affected and you start preparing your patient accordingly, correct? I don't know if there's a specific inflammation question there or
Yeah, I think EBV reactivation is quite common in Shirya-Kagashi. So that's something you
yeah,
should worry about,
you should
or
always
check the
monitor
EBV
that.
copy numbers. Yeah.
Yeah. Yeah.
And then there is next question. Is there any infection marker cutoff in case of SCID children for transplant eligibility? That's
None.
Subhashish.
No. It's a skid. So this is what I'm saying. Like the issue here is like because we have newborn screening, we don't see these patients with infection. At 12 weeks, they're going to transplant. Very, very simple, easy, simple process. We put a line a day before, do a ECG echo the same day as an inpatient so that they don't have to go to the echo room. Next day, start conditioning. Because we are capturing them before even the first infection, our outcomes are very, very good. Like we have no mortality for
So,
SCID.
so one question on such small children, what sort of conditioning you use? Like 12-week-old, you use Trioflu, or
We
what do you use? Yeah.
yeah, we are triosulfan based center. Yeah, we don't like busulfan at all. We have a trial which is open, the seaside trial, which they are seeing the what is the difference between a bu high dose versus or a medium dose versus the low dose. So that is trial is still ongoing, but that is a North American trial, and we were a participant of that. But we are a triosulfan based center. Trio is not available in the US as of now, so it'll
So
soon be available there.
questions are
Yeah,
still coming. Virendra Patil
yeah,
has asked you, a patient post vedolizumab developed progressive myeloleukoencephalopathy. Did you have any such experience or complication?
no. There can
Yogi,
be other there can be other reason. Yes, Dr. Bhatt, how are you?
Sunil.
Yogi, a very simple question. We are in India, so we see a significant number of patients, MSMD as well as non-MSMD,
Yes,
who have received BCG and have BCGosis, BCG disseminated BC infection, or even
yes.
tubercular, non-tubercular infections at the time of diagnosis. It's always a question how long to wait and how long to treat before you take them up. So you
Yeah,
have had, I know you may not have that many from your own cohort, but expats, people from this part of the world, or patients who have come to you from elsewhere. And what has been your strategy in these patients?
yeah. So that's a very good question. We don't see that scenario. The reason is because BCG is not given here at all. So that's the vaccination. Regarding the expats, we have not been in that complication as of yet. But hopefully soon will be because the way the immigration is, we might suffer that. But we have not landed up with this. This is a tough question though. When to take them to transplant? So I had a patient who had developed not BCGosis but had an atypical MAC infection. Very difficult to treat. The treatment duration is sometimes it was in the lymph node, and treatment duration can last from 1 to 2 years. So in that scenario, what we did was we waited for a year to make sure that infection is under control. We saw that there was some calcification on the lymph nodes, and then we took them to transplant. But the issue with that therapy is because everything you give interacts with your chemotherapy, interacts with your post-transplant immunosuppression. So you have to be careful. You have to make a plan with the pharmacist before which is the minimum agent which I can use at that time point so that it doesn't interfere with my chemotherapy. It'll be kind of a break at that time point from few of those medications, but try to follow or find an alternative medication which can be used in that scenario so that you don't land up in trouble. And once you have gone through the acute phase and then you whether you're using tacro or cyclospore, and then you can modify those antitubercular agents to whatever is possible at that time point. So that is what we did for the kid with the atypical mycobacterium. But yeah, like that is a difficult, challenging scenario. Yeah.
So, just a comment, like we had something similar. We had a kid with Viscott-Eldridge syndrome. I think you know that kid, Veer Kuba. So that
Yes.
baby after transplant had BCG reactivation in the axilla, and after 2 years, we had to drain, and a pus was drained from there, and it was a huge abscess which was formed. He was on INH prophylaxis for a long time and did very well, but the infection can persist for quite some time. That's true.
Yogi, I want to ask a question.
Yes, sir.
So once you throw in like vedolizumab, or maybe sometimes you have to give Inflix or anakinra type of a thing also. Then
Yes.
now since letermovir is available, are you
Yes.
using it early before the prophylaxis of CMV, because it starts like week -6, and then a lot of inflammatory management. So have you guys done it, or you have a thought about it? If you use
Yeah.
letermovir there also, will that help? What do you think?
It may help, but we are not using it because of the cost. The cost is very high. The cost for a treatment for 100 is $40,000 Canadian.
Okay, so
So that is the reason. That's not a standard of care. Yeah.
it's wonderful discussion, and questions are still coming, but due to lack of time, we'll have to wind up here. So Yogi, thank you so much for an interesting session, top-notch session. You made it so simple for everyone. Thank you. And we finish here. Thank you, Ramzan, for chairing this session. And now I would hand over the next part to Dr. Sunil Bhatt to take over and take it forward. Thank you.